First, we have, on the end, Dr. Cheryl Helton. She is the founding president and CEO of Legacy and has worked to further the foundation's ambitious mission, which is to build a world where young people reject tobacco and anyone can quit. That would be a lovely place. During her tenure with the foundation, she has guided the highly acclaimed National Youth Tobacco Prevention Counter-Marketing Campaign, referred to as TRUTH, which has been credited in part with reducing youth smoking prevalence in near record lows. Under her leadership, Legacy, which is dedicated to evidence-based public health strategies that work, has taken numerous other public education campaigns, research and technical assistance, and a broad program of grant making. Next, we have Dr. Andrea McKee. She is currently serving as the chairman of radiation oncology at Sophia Gordon Cancer Center at the Leahy Hospital and Medical Center in Burlington, Mass., not very far from here. She is also senior partner at Radiation Oncology Associates of New England and holds a teaching appointment as an assistant professor of radiation oncology at Tufts University School of Medicine. Dr. McKee is currently on a staff of 10 other New England hospitals. In 2012, Dr. McKee and a team of allied health professionals at Leahy initiated a free CT lung screening program to save lives and open screening access to those at high risk for lung cancer, regardless of their financial means. At that time, she founded the Rescue Lung, Rescue Life Awareness and Advocacy Movement, a campaign to save lives through enabling access to responsible, free, or low-cost, low-dose CT lung screening. Dr. McKee has also collaborated with cancer advocacy and occupational risk groups, including Lung Cancer Alliance, Professional Firefighters of Massachusetts, and Vietnam Veterans of America, to bring about the goals of saving lives of those at risk or high risk for lung cancer and establishing a CT lung cancer reimbursement, screening reimbursement. And last but not least is our token male, Dr. Jim Mulshine, and he is the Vice President and Associate Provost of Research at Rush University Medical Center in Chicago. In this capacity, Dr. Mulshine is the primary academic officer responsible for managing research activities at Rush University Medical School. He is an internationally recognized expert on lung cancer, and at Rush, his research concentrates on the management of early diseases as a key to success in improving outcomes with lung cancer. Dr. Mulshine was previously at the NCI for 25 years, where he was on the research faculty. While at NCI, he served as the head of intervention section, chair of the lung cancer and chemoprevention faculty, and chair of the institutional review board. He was also the NCI representative to Technology Transfer Review Subcommittee for the director of National Institutes of Health. He has been awarded 12 patents and has over 300 scientific and medical publications. Committed to continuing medical education, Dr. Mulshine is on numerous editorial boards and sits on national and international scientific and foundation advisory boards. He was recognized for lifetime contribution to lung cancer prevention by the International Association for the Study of Lung Cancer. Let's welcome our speakers.
I just lost use of my glasses, but I think I'll be able to limp along here. Welcome, everyone. I'm delighted to be here to give I hope, a truncated talk. Don't take up too much of your time today on the issue of the myths of lung cancer screening. You probably know many of them, but let's start with what we ought to know by now. Lung cancer is the second most common cancer in men and women, but it's the leading cause of cancer death in both sexes, accounting for 28% of cancer deaths in men and 26% in women. The American Cancer Society estimates that 228,000 men and women will lose their lives each year in this current year that we're in, 2013, due to lung cancer. It constitutes a significant burden of disease, second only to heart disease, and it accounted for 2.9 million years of lost life in 2010, which makes it very much at the very top of the hit parade for loss of life. Long-term observational studies and other randomized controlled trials have shown that there's potential benefit to screening. These figures here of 7.16% of lung cancer deaths in the U.S. each year among 8.8 million Americans eligible for screening are really the low estimates based upon what happens early on. What will happen ultimately as we institutionalize screening in the United States of America will be an entirely different situation. As screening becomes the norm, among those at risk, the numbers identified at the treatable stage will rise, and so will the mortality benefit. So the 20% mortality benefit that came out of the big national lung cancer trial really is very much a floor. It was based on a baseline and 2 subsequent screenings. The actual likely mortality benefit is substantially higher, and I suspect my other panelists will discuss that. I raise that because clearly one of the issues in terms of expanding screening in this country is first to get through the comment period and get an A or B rating. My guess is it will be a B, which is what was proposed by the U.S. Preventive Services Task Force, and then to have it on the list of essential services throughout all of the state Medicaid plans and covered by all sorts of other insurers. But the other side of the equation is for patients to feel that they derive some benefit. So one of the points that I think is very important to take home is that the level of potential benefit is understated in most of the popular press at this point, and that may continue for a while. The task force is proposing, as I think you probably know, that CT scans occur for current and former smokers aged 55 through 79 with a history of heavy smoking, the equivalent of 2 packs a day over 15 years or a pack a day over 30 years, and that have smoked within the last 15 years. So if you have quit and it's been 15 years, you don't fall within the screening recommendation. For a variety of reasons, I don't agree with that. I'll show you a few slides in a minute as to why I hold that opinion. I don't think I'm alone, but I'm sure there are many on the other side of the equation. Under this narrow definition, many of those who are at risk will be excluded, even though they will continue to have lung cancer risk and ultimately be diagnosed with lung cancer. Legacy commented very extensively on the recent comment period for the U.S. Preventive Services Task Force. Legacy is the leading public health anti-tobacco foundation in the U.S. created out of the litigation between the state's attorneys general and the tobacco industry. So one of the first things we don't agree with is the 15 years, and we don't agree with that because the risk to the smoker of developing lung cancer who has smoked at those levels, one pack year, 15 years, or basically a pack year over a period of time or more. In the case of many smokers, their risk of developing lung cancer does indeed decline as time goes on, and they do not develop lung cancer and remain a non-smoker, but never comes back to that of a never smoker. And that's illustrated in this slide, which is not all that easy to read, but it shows the year that one quit and the continuing risk of smoking, the age at quitting, and it is from the physician study in Britain. And so it's clear that while your risk is lower, it is definitely not that of a never smoker. And the same is true here in another study that looked at the population benefit and the deaths per 1,000 over time based on the age of the cohort and the age that they stopped smoking. And again, no conversions of those who are never smokers or non-smokers with those who smoked and quit at any time. The racial gap. We know that African American men in particular are 29% more likely to be diagnosed with lung cancer and 24% more likely to die of lung cancer than white men. There are many explanations for that, and I believe there remains some debate in the literature about the source for that difference. Part of it is later diagnosis. Another is the sense that for cigarettes smoked, there's a higher lethality with the African American community remains not fully understood. And then, of course, the smoking rates among African American men, as this has become more an epidemic of people of lower socioeconomic strata, have crossed over white men, such that more black men smoke than white men. That was not previously the case. Access to care, obviously, those of lower socioeconomic strata have lower access to care. We hope with the Affordable Care Act there'll be some improvement with that. And if we not only get screening and reimbursement for screening and a robust Affordable Care Act, presumably there will be greater access. More on the access to care, okay. The gender gap, you probably are aware that per amount of tobacco smoked, women appear to be more likely to develop lung cancer, and they also tend to develop lung cancer at an earlier age, at least in some studies that's been demonstrated. And so one of the points that we also made in our letter to the U.S. Preventive Services Task Force is that we believe the age should be earlier for women for screening. We also understand that the years of life saved are greater for women simply because women live longer as well. So not only do they tend to be diagnosed a little bit earlier, they tend to live longer. I'm not going to belabor that point. The other thing, of course, which I just said is about living longer. Now, saving lives and cessation. We just completed a study with the Milliman actuarial firm together with scientists at Legacy that modeled in an insured panel of patients what would be the cost per life saved if you simply undertook a screening intervention that followed the same model that was in the National Lung Trial and did it with cessation services. And then among cessation services, did it with kind of the Chevy variety of cessation services and the Cadillac variety. And what we found was that even without the introduction of cessation services at the same time that one is doing screening, which for a variety of reasons is very much warranted, but even without that, the cost per year of life saved, the cost utility of lung cancer screening was very comparable to other forms of mass screening for cancer that we undertake, such as colon, mammography, and cervical cancer screening. When you included smoking cessation interventions of either the Cadillac or the Chevy variety, the cost effectiveness of screening rose by 20 to 45%. So another strong public policy reason for including cessation services as a part of what you're doing. Studies have shown that the qualities of life per year are about 16,000 per life to 23, depending upon the modeling, and those again are very, very comparable to similar figures for other forms of cancer prevention. We also know that cessation in a screening context works. There are a number of studies. There's only one study that I read that had other than a result for a positive impact of cessation services provided at screening, or even the very active screening and its effect on subsequent use of tobacco. And in both those sets of studies, there was only one study that showed an increased intention to smoke among a subgroup, and it did not measure actual smoking behavior. All of the rest have shown that being screened, particularly being screened with smoking cessation interventions, has a positive impact on quitting smoking. I think, as you know, the improvements that have taken place with LDCT technology are such that getting lung screening is now roughly the equivalent of having mammography screening. So there is another big myth out there in the literature that this is a deadly intervention as opposed to a life-saving intervention. We've talked about the lives that can be saved. I deleted the last slide because in the interest of time, but I think I have 1 minute to cover it. And that slide showed the change in years of deaths worldwide among men and women by country. And basically, no surprise to all of you, the bulk of the lung cancer deaths follow the tobacco use epidemic. And so those deaths are disproportionately high in industrialized developed nations, but they are rising all over the world because of the continued success of the tobacco industry in marketing its product globally, such that the prediction now is that in this century, 1 billion people worldwide will die of tobacco-related causes. Last century, it was 100 million, so a 10-fold increase in the lethality globally of the tobacco product in those 2 centuries. And then the sort of extraordinary statistic is that the global deaths due to lung cancer, and this intervention is not just for the US, it's an intervention that can be used many places, and increasingly as countries become more financially secure, will be used in countries that are now considered low middle income countries or low income countries. The global burden is about 1.4 million deaths a year, and HIV/AIDS is at 1.6 million deaths a year and going down. So sometime in the next few years, we will see tobacco-related lung cancer deaths surpassing AIDS deaths worldwide. So that tells us something about the trajectory of this epidemic. And thank you for your time. Can I take the pointer? Yes, thank you.
Good afternoon. Thank you for coming. I'm going to talk about implementation of low-dose CT lung screening programs, which, as if any of you out there have already tried to implement programs, you know can be a challenge. I have no disclosures. So there have been decades of research regarding the use of low-dose CT and a variety of other screening mechanisms that I think Dr. Melshine will probably talk about that came before the NLST trial. But the NLST trial really, because of its design and its power, sort of has really ended the discussion that there is, in fact, a mortality benefit to low-dose CT lung screening the high-risk population, and it is, as Dr. Hilton pointed out, at minimum of 20% in the confines of that screening trial. Shortly on the heels of the publication in the New England Journal of Medicine in June of 2011, the NCCN, the National Comprehensive Cancer Network, I don't need to explain who that is to this audience, developed the Lung Cancer Screening Practice Guideline, which is a terrific document. And anybody who's starting a lung screening program, I highly recommend that you get a hold of this and that you look at it very closely. What we did with the Rescue Lung, Rescue Life program is we essentially operationalized the NCCN guidelines. We wanted this to be evidence-based, and so we used that document. But we realized early on that there were considerable barriers to translation of this research into clinical practice, the number one of which is clearly patient cost. And I think probably most of you out there are struggling with this issue, as it is clearly one of the greatest barriers to patients getting screened at this time. But there's a lot of other barriers. That's not the only one of them. And one of the big ones is actually the amount of change that your organization has to go through if you're going to implement a responsible low-dose CT lung screening program in the era of reimbursement. Once we're actually screening patients, it has a tremendous effect on your organization. So we knew we needed a large group of people in order to overcome some of these barriers, and I have them listed here, and many of which we've talked about, and we will talk about. But a couple of things I just want to mention specifically was the primary care physicians' concern about how this would influence their practice. They are very busy. They don't have a lot of time to be introducing new discussions with all of their patients, and so we knew we had to address that in some way, which I'll talk about. We also felt very strongly we needed a process for informed consent as patients began to consider whether or not they wanted to engage in screening. Cheryl did a great job talking about radiation exposure and the myths that had to be debunked with our primary care teams about that risk. Also the prejudice, huge amounts of prejudice. When I first got out and started talking to physician groups, surgeons, people who make their living treating lung cancer, I was really shocked at what we would come into, and you're gonna find this in any practice that you're in, I'm sure. And you just have to try to educate and just stick to the facts and just keep moving it forward. Surprisingly, competing funds. We were on a panel a couple of weeks ago where we were hearing about how some of the smoking cessation groups were really kind of threatened about the prospect of inviting lung screening in because they were worried that there would be competition over the sparse amount of funds that are allocated towards primary prevention, and they didn't want to have to share with secondary prevention. The fear that we might encourage smoking through screening, and Dr. Hilton talked about that, as well as you'll hear if you start talking with your teams about lung screening that everyone's going to be very fearful. There's so many uncertainties. You'll hear a lot of uncertainties whenever you start talking about lung screening. And yes, there are some uncertainties about lung screening. You know, who else needs to be screened? Is there a group of patients in whom they don't need annual screening, but we can change that, the period of screening? Do we use volumetric screening, or do we use just axial dimension screening? There's all sorts of concerns out there, but we think, and that this is our what we maintain is that we have enough information to screen the high-risk population now. We know that this group of patients benefits from screening, and our biggest challenge right now, rather than talking about the fears, which we'll have plenty of time to work out over the next 10 years through research, our biggest challenge is to get the people right now who need to be screened. Managing the findings is an issue. We have a system called LungRads that we use to manage the findings on behalf of our primary care team. The uninsured, if you are in a state that has a high uninsurance rate, that can be a real obstacle. We're fortunate, I'm in Massachusetts, and so we have like a less than 2% rate of uninsured, and so we were able to manage that uncertainty. Anxiety and cost society are the last things, and I think Cheryl talked about the cost issue nicely. So with all of those barriers, we knew we needed a really powerful team to overcome them if we were going to ask our hospital to offer low-dose CT screening at no cost to our patients. And so this is the steering committee that was assembled on the heels of the NCCN recommendation. You'll see on the left are all the physicians, on the right is all the administrative support, and this isn't even everybody who was involved, but this is the group that continues to meet on a regular basis. We have 2 vice chairs of radiology in our radiology group. I'm the chair of radiation oncology. Paul Hesketh is our section head of medical oncology and also now the director of our cancer center. Guy Napanatala is our chair of GIM, cardiothoracic surgeon Christina Williamson, who does most of these surgeries. Laboratory medicine involved now because we are integrating a variety of research questions into our program. Andrew Villanueva is the chair of pulmonary medicine and also at that time the chief medical officer at Leahy. So we knew we needed a coalition, and you do need a coalition. If you're going to offer free screening, you can't do it by yourself. You need a whole team of people, and the administrative support, which you see listed here, was tremendous in this process as well. So once we identified our coalition, we needed to create a sense of urgency, which is what is recommended when you bring about organizational change. And you've heard from Dr. Hilton about the sense of urgency. And I think one of the ways to think about lung cancer deaths is that there are 450 people dying every single day. It's like 2 747s colliding on a daily basis. It's just, we don't even comprehend these numbers. It's so many people. You know, if you heard about this on the nightly news, you would be just continually overwhelmed. And we know, and this is, Dr. Milshine, you see your quote there. I use your quote all the time about how the greatest potential impact on cancer mortality since the history of war on cancer began can be realized through screening. We know that at least 50 of these people can be saved every day. And right now, if we are saving any of those people, they're all in first class. They're all behind the curtains, and they're all up in that upper cab. And what we're trying to do is also create a sense of urgency about opening access to the rest of the cabin. So we went to our administration and we talked about the unprecedented opportunity to save lives, which is terrific, but it's actually not enough. If you go with just that, you're probably going to have the door shut in your face. We had to show that this was self-sustaining from a financial point of view, and so we developed a financial model, and those models are available to anyone who wants them. They're on our website. You can plug in all your own numbers based on your demographics and your costs. And then you can really manipulate these models, as a variety of them, to determine what impact this could have on your center depending on what you charge for screening. We are an ACO. For those of you who just listened to the panel discussion beforehand, you'll understand that ACOs share in the risk of managing their patients, and our senior administrative team really thought it was important to try to diagnose lung cancer at earlier stages where it's much more effective in terms of our treatments, and also we think there's much greater value. But the thing that they said that really impressed them and why they moved forward with giving us approval to do free screening was because of the fact that we had this entire team that were all behind it. It wasn't just oncology. It was oncology, it was general medicine, it was radiology, it was pulmonary medicine. It wasn't coming from one small portion of the organization. It was really coming from a large front. And we showed that it is free lung screening or no cost patient lung screening is in keeping with the hospital mission, which is to save lives, demonstrate growth, innovation, sustainability, and teamwork. This is one example of what you might see if you look at our cost analyses, and this is just in the first year of screening. And one of the things I'd like to point out is that in the first year of screening, 70% of any downstream revenues from a screening program are associated with the treatment of lung cancer, and for the most part, the treatment of early stage curative lung cancer. So in effect, what you are doing is you are shifting costs out of the future from medical oncology and radiation oncology into surgery and radiology at the present. Over several years, this starts to, the radiology revenue start to sort of catch up, and it becomes a little bit more equal. But in the first several years, it's primarily coming from surgical treatment, value-based. This is the timeline. So in November of 2010, the NLST was halted, and we were just floored. We all expected it to be positive based on the ILCAP information and what we had learned through our own following lung screening, but we weren't an NLST site. We were not an ILCAP site. We'd never screened anybody. So we knew we had a lot of work that we were going to have to do if we were going to screen people. And the first thing we did was to try, just a small group of us, to get a discounted rate. And we were able to get a rate at $350 for about 9 months. We screened 4 patients. And this is what I hear from everybody. I hear it at $350, I hear it at $125, I hear it at $75. I don't know about 25, I haven't heard that yet. Is anybody at 25 and is actually getting volume? So 75 is not low enough. There may be something between 75 and free that brings that barrier down, but I haven't seen I haven't seen that yet. So we, after the NCCN, we got serious. We developed the steering committee. At the same time, a simultaneous radiology working group, because the majority of work that is done on this program really does happen in radiology. And so this group reported to this group, and we were able to develop our processes in order to, within 6 weeks, we set a go-live date. We met December 6th. By January 9th, we said we're offering free screening. Now, of course, we did not advertise. We never advertised. We've never had a direct-to-patient advertisement of our program. We let our employees know through our hospital-based intranet system that we were offering free screening, and that's how we first started to get the word out. But all of our patients really have come through our CME campaign. We took the discussion, we took the CMA talks to the primary care physicians. We taught them what the issues are, and they send us the patients. And now we have about 20 new patients a week, and we've been pretty steady at about 20 new patients a week since we implemented the program and really got out there with the CME campaign. So this is what we talked about when we met with them. How are we doing it? The 20% is the floor. The most important safety element, which is to not intervene unless the patient is a high risk, which in our situation is category 4. And I'll tell you what that means in terms of our lung-rad system. Radiation risk, informed decision making, we had to show them what that looks like. And we do assist them with documents to both the patient and the provider to help them to talk about the risks and benefits of screening through the primary care. The importance that they play in smoking cessation, which we rely on our PCPs for that. We do have a free quit program at Leahy, but for the most part, they're accessing their smoking cessation efforts through their primary care team. I'll talk a minute about medical legal considerations and the how and the why free, because some people were really angry with us that we were giving away health care for free. And so we had to explain why we were doing it. So we report our findings out of radiology based on what is currently done in mammography. Mammography has been used for decades. It's federally mandated how you perform mammography, how you issue the reports to the patients, how you report out the findings with the BI-RAD system. Every center across the country, if you are doing mammograms, you're doing the same thing. We feel the same thing needs to happen for lung screening. We already know the system works. It's very easy to adapt this to lung screening, and it has all the important tools to be able to report quality and safety to keep the patient safe. So lung-RADS is based off of the NCCN recommendations at the time. They've since changed them, but at the time, so a positive nodule, which was the same as the NLST, is greater than 4 millimeters. Solid nodule, this is just the solid nodule. There's a variety of different one's recommendation sheets, but I'm just going to go through the solid nodule one. If it's between 4 and 8 millimeters, it's just a CT scan in 3 to 6 months, and we manage that all through radiology. That's all handled through radiology, so the primary cares are not managing this group of patients. They just have to write the orders, but we're making the recommendations, and they know it's based on guidelines and evidence. If it's greater than 8 millimeters, which is our suspicious Lundgren's category 4, we don't recommend PET CTs. We don't recommend anything other than a pulmonary referral. And it doesn't have to be pulmonary. In your system, it could be cardiothoracic surgery. It could be a medical oncologist who has an interest in this. You just need some physician at this point to come in, get a history, tease out what's going on, and recommend further evaluation. And these patients are the patients who access our multidisciplinary clinic as well, so that that doctor brings that patient to our multi-D conference. This way you're triaging risk and you're not having multidisciplinary teams see every single patient with every 5 millimeter nodule, because those patients, right in here, these patients between 4 and 8 millimeters, 98% of them don't have cancer. So why do you want a multidisciplinary team looking at them and potentially operating on them when most of them don't have cancer? Wait and see what happens when it starts to grow, then it becomes a category 4, then they meet with the multidisciplinary team. So this is same as mammography, category 1 negative, category 2, there's something there, but it was there 2 years ago on a CT and it hasn't changed, so it's benign by Fleischner. Category 3, there's something there, but it's between 4 and 8 millimeters. It's most likely benign, probably benign. This is the same as mammo. Category 4, positive, suspicious for malignancy. All comers, this group, about 20% of them actually has cancer, but it can be, that range obviously changes, because you can have somebody with a 10 centimeter mass who 100% probably have cancer, and you can have somebody with an 8 millimeter nodule. Category 5 is known cancer. And then the only difference between lung RADs and BI-RADs is this S category, which is significant for an extra pulmonary finding, because we look at more than the breast do in mammography. We look at the chest, which also has blood vessels and thyroids and kidneys and livers. And so if there is a significant extra pulmonary finding, that's reported as S positive. So to reassure our PCPs, how am I doing on time? Okay, I have to go faster. To reassure our PCPs, we asked them, so how many patients do you actually see? And they told us they see about 2,500 patients a year. And it's important for your PCPs to know that it's only about 3% of your population who actually qualifies for screening. So it's not like they're counseling all 2,500 patients about screening. You need a mechanism in place within your office to identify who are the high-risk patients. But once you've identified them, then you have the discussions, the targeted discussions with the ones who are at risk. So that's about 75 patients who qualify and potentially undergo screening, 20 who will have a positive nodule in the first year of their screening. That goes down on their prevalence screens. And 5 patients who will have a potentially significant incidental finding that they're managing over the course of a year. Leahy, we think we should be screening about 100 patients per week. Right now we're at about 60 to 80, depending upon the week. During this time, we will diagnose 1 cancer per week. We'll have initially about 27 positives. That goes down again to less than 20% once we're in our steady state, and 7 potentially significant findings. After 2 years, we'll save 1 life every 3 weeks. That's a minimum. So this is a big, just at one center. And you're going to feel this at your center right away. We already feel all of the patients who now are coming in with stage 1 and 2 lung cancer, mainly stage 1, as opposed to stage 3 and 4, which is what we're so used to talking about in our MTOC. Smoking cessation, I'm not going to cover, except to say that 60% of the patients in our program are former smokers, and the majority of patients nowadays who die from lung cancer have already quit. So smoking cessation is not going to help them. They've already done the heavy lifting, and again, I think you did a good job talking about smoking cessation. The Lung Cancer Alliance is just a terrific organization. I can't say enough about what they have done. They have a beautiful framework for excellence, which you should all take a look at. I think there's some documentation outside. They also have this recent Right to Know campaign, which is essentially saying that you have a right to know if you're at high risk for lung cancer. And this is an advertisement campaign that is being launched across the country. Furthermore, it's saying you have the right to know about the facts surrounding low-dose CT lung screening. So keep this in mind in terms of when you go to talk to your primary care physicians. This is all the societies who endorse screening for patients. So if your primary care teams are not discussing lung screening with their patients and documenting it in their charts that they are having this discussion, this is a significant medical legal risk in the future. There's loads of precedents about failure to screen lawsuits in this country, and typically jurors side with plaintiffs when it comes to these situations. So these conversations need to be happening. Patients need to know if they're at risk, and they need to know the facts about lung screening. And furthermore, the American Cancer Society in their guideline goes on to say it's the physician's responsibility to actually get them access, direct them to a responsible center who is screening. I talked a little about why cost-free, the ethical issue, but also just the motivation of if you make something free, people talk about it. And a lot of what's happened is we've sort of forced the issue on our primary care physicians and our patient population. Okay. Low-cost model, we basically used installed capacity on our scanners. So we essentially identified spots on our PET CT when the injection happens in the morning, but the patient doesn't get scanned for an hour. You can screen 5 lung patients during that time. Team's already there. You've already paid for the scanner, so we just slip in. We just looked across all our schedules in radiology and looked to see how to do it. There are some compliance requirements that you need to know about. Patients must meet established program guideline criteria. So every patient in our program right now is either NCCN Group 1 or NCCN Group 2, and we centralize that through radiology. That we cannot charge anyone for screening, even if it is a covered benefit. So for example, Blue Cross Blue Shield of Massachusetts does cover this, but we're not allowed to charge anyone. We cannot tie any follow-up testing to the free screen. So on every piece of literature and everything that you see on any one of our program materials, it says you are under no obligation to return to Leahy for any additional testing or treatment. Your scans are available by this mechanism. Patients can go wherever they want to have downstream treatment, and that's made very clear across all of our teams and all of our literature. And once CMS does decide to cover this, we are going to charge. This is not we're not doing this forever. Once there is coverage and there's access according to standardized channels, we will then provide lung screening as we do any other service. All these materials are on our website. So you can get them, and you probably have these screens too, but this is just a flow sheet of how it works. These are the quality metrics that we follow. They're essentially the same as what's described in mammography. Again, we already know this works well with mammography. Let's use it in lung screening. So FP1 is your overall number of positive studies. FP2 is those who are going to go have a biopsy, and FP3 is of the ones you biopsied, how many had cancer. But also, we track the S-positive rate, which we think is important. Ours is actually lower than the NLST. It's about 3 to 4%, and we think that's because we have a lot of old films on our patients. And we also track the number of PET scans. You need to have someone. We have a nurse navigator and a program navigator now. We didn't have anyone when we started. And so if your program is small, you just need to identify somebody who's actually following these metrics. Okay, I'm done. These are the patients. And this is, again, all on the available to you. Okay. Thank you. I knew I wasn't going to get it. Sure.
Gee, I think I should yield a few minutes. I'm interested in hearing the next few slides. It's a pleasure to be here. It's always nice to come to a city where the mayor says such nice things about the town you're from. Those hockey fans will understand the reason for that. In any event, it's a great time for screening. Some of us have been involved with this for a while, and it's just nothing short of amazing to see the transformation in the field evolving over the last couple of years, in part related to the people talking to you today, in part related to the work of the Lung Cancer Foundation, Lung Cancer Alliance, who Amy Copeland's here with some materials if you want to follow up on the framework that Andrea talked to you about. And Cheryl and I had the pleasure of being on the board of that foundation, and they have fought a war behind the scenes to allow the people of the United States who have been addicted because of the malicious marketing of the tobacco industry of children to finally have health care benefits so that they can have a hope of living a normal life. If I could have the next slide, please. I guess I have that. Thank you very much. For the purposes of this, I have no disclosures. I'm going to show some of the slides you've already seen, and You've already heard about wonderful aspects of them, and talk about a few complementary perspectives as well. So one of the key things to understand is, in terms of tobacco-related disease, we're talking about a massive public health problem in the United States, across the globe. And what people are surprised to find out is, of the well over 400,000 deaths related to tobacco each year, 123,000+ of them are related to lung cancer, the largest cause of tobacco-related death. And as Cheryl pointed out, and I'll come back to, this is the major driver in the cancer sphere of premature death, perhaps 3 times the premature death for lung cancer that we see for breast cancer. And I'm not undermining, I don't want to short shrift the public health impact of any of the cancers, but premature death has a particular importance in terms of economic analysis, as we'll discuss. This is the slide you've already seen. This is from Dahl and Pito. And I want to just emphasize on this slide that, as you can see, if someone stops smoking at age 30, you see from the slide, over the next 30, 40 years of life, that curve does not return to normal. So underneath those curves, in aggregate of non-smokers, is actually 48 million of your fellow citizens. 1 out of every 4 people is a former smoker. And they are the ones that have this elevated life risk, and they are the ones that lung cancer screening is an unbelievable opportunity, because but for that, they would potentially have an option at a much longer life. So we've heard about the National Lung Screening Trial. The thing I want to say about it, I think it's already been covered, is that this large, well-designed trial was designed to look if there was a significant benefit of screening. It was not designed to detect the full benefit of screening. And the reason for that is, just doing this preliminary look to see if it was at least a 20% mortality reduction benefit cost $250 million. To do the full study of the full benefit would have cost several times more than that, and it was absolutely unthinkable from a budgetary perspective. So we got the answer. Yes, unequivocally, there is a mortality reduction benefit in a gold standard clinical evaluation. This is the survival curve. Now here's a little bit more granularity. So the NLST came up with this 20.3% reduction compared to the chest X-ray arm in the NLST. But if you modeled a dynamic in which you continue to screen, not just twice, not 2 annual follow-ups, but continued, and that's what happened in the New York LCAP, and they could do this analysis because New York State has a death registry that tracks all the long-term causes of death and is used as a public health standard for all kinds of analysis. From that, the group at the ILCAP, led by Claudia Henschke, was able to show, under different scenarios when you looked at it, the mortality reduction benefit of the annual screening that went on in the state of New York, initially led through all the other academic medical centers in the state, was somewhere between 36 and 64% mortality reduction benefit. And that was an analysis published in Cancer, done in concert with a very esteemed epidemiology group. Then, under the funding of the National Cancer Institute, Dr. Foy's paper was published about the same time, and that was a separate modeling event led by a group out of Rice University, and they looked at modeling as opposed to the clinical outcomes that Dr. Henschke was able to do. And using the CISNET modeling approach, they came up with a 46% mortality reduction benefit under their most reasonable set of assumptions regarding the modeling analysis. So I think the conclusion is the true magnitude of the benefit of lung cancer screening is not yet known. Now, we've already heard from Cheryl about certain of the work done by Bruce Pyenson and his group of actuarials that I had the privilege of being involved with for their preliminary 2 analyses. And this was to try to get our arms around the cost benefit of lung cancer screening. And this is the middle of the 3 papers that Bruce was involved in. And it had very similar results to have already been discussed, but I want to just say a couple of things that as a medical oncologist, I learned working with these people in the process of this analysis. Lung cancer screening appears to have very comparable costs or lesser comparable costs to breast cancer and colon cancer screening. And I'm a massive supporter of breast cancer and colon cancer screening. But the reality is, for all of these things, all we have is the healthcare costs. And so the cost is really prejudiced towards the initial healthcare expenditures. And what we can't really take into a full account is that 50-ish-year-old former smoker who has a stage 1 lung cancer detected that otherwise would never have been apparent if they hadn't participated in screening, and continues to live a healthy life for the next, I don't know, 10 years, 20 years, 30 years, 40 years, whatever it is, and continues to earn a wage, continues to pay insurance, continues to pay taxes. This analysis was done in Canada, and if they increased the lung cancer outcomes by 50% compared to what they were doing currently, and this was presented at a World Lung Cancer meeting about 3 or 4 years ago, they basically showed that they had a profound and measurable impact on the gross domestic product of Canada. And so that there was a profound economic loss related to premature death, related to lung cancer, that they had never been able to account for previously. So we've got to develop more sophisticated metrics to measure the value of these preventive services. Because think about this from the cardiovascular world. In the world of managing heart disease, the mortality of cardiovascular disease has reduced 70% over the last 3 decades. And yet, no one thinks anything about it because we really can't value the productivity of all those lives saved for all those years. So this is a gap in our knowledge, and we've got to work on continuing to figure out how to develop these preventive tools and how to more appropriately value them, because right now, our way of doing it undervalues the contribution of these things to our economic productivity. We've already heard about the issues with reimbursement. The one thing that I would say about this is that 90%, Tobacco-Free Kids provides a lot of this information. Tobacco-Free Kids is primarily sponsored by this foundation. I forget the name of it. Legacy. I knew it started with an L. No. And they're just unbelievable in terms of shining a bright light on these facts. So we know that 90% of the people who smoke start smoking by age 20. We know that most of these people that start smoking, most of the children that start smoking, 1/3 of them smoke for the rest of their life. And so we're addicting the most vulnerable part of our society. And this is all documented in Judge Kessler's statement from her indictment of the tobacco industry several years ago, which, again, the Legacy Foundation had a big role in. And then these are the people that go on to smoke, and some of them can stop, and some of them can't, and many of them, up to, of the chronic smokers, half of them die prematurely related to their childhood error of starting that habit in the first place. So the obligation for us as a society to provide resources to allow screening to go after a population that was systematically targeted in a manipulative way is just an unbelievable social justice issue. And 10 years from now, we'll be wondering, why was anybody ever thinking otherwise? Because the inherent social justice case here is so strong. So, and yet, the reality is, and we've already heard in the previous sessions, that there's not unlimited healthcare dollars. So what I've outlined here is there's a number of steps in the process of screening, and Andrea's characterized many of these things. And there's an enormous learning curve in learning to do this new kind of lung cancer management in an efficient and high-quality way. And your group, this meeting is all about high-quality cancer care. So we're delighted to be able to sharing these new perspectives about beginning to do national implementation of lung cancer screening. And what you need to do is understand, how do you pick the right population? How do you do the diagnostic workup? When do you know to do these invasive interventions? How frequently do you bring the people back? All these points are things that we haven't answered today, but none of them are truly optimized. And to the extent that you can define that, you can increase the efficiency of the care delivery. As you increase the efficiency, you decrease the cost, and you decrease the wear and tear of the people going through the process. So it's an enormous opportunity. And fortunately, this kind of continuous quality improvement is what the Institute of Medicine has been talking about, and you've been actioning in a lot of other areas of cancer medicine. So this is an enormous opportunity to just leverage what you've been doing all along, and it's all driven by data. So we want to move to rapid learning. We want to leverage what the Institute of Medicine has been talking about in terms of taking transactional care data and looking at that relative to quality and looking at that for process engineering opportunities to make it better, cheaper, and faster. So one example, the Nelson, which is the Dutch version of the NLSD, is a study that was published in the New England Journal a couple years ago. And they just showed their diagnostic workup, not the long-term mortality outcomes. In that, they showed by using a technique that was pioneered by the group in ILCAP, they could get a 95% sensitivity, 99% specificity by not jumping on every nodule, but rather looking at nodules that grow over a time interval. And the ones that are growing rapidly are the ones that then are subjected to invasive diagnostic workup. And then by doing that, like Andrew was talking about, you take this false positivity rate from some very high number down to 15% in the NLST, down to 3% in Leahy Clinic, down to 3% at University of Toronto that just published last year its results, prospectively managing 7,700 people that way. When you take a false positivity rate from 20 down to 3, that wrings out enormous cost and enormous wear and tear on patients in the process. So the opportunity to do rapid learning has been realized in this recent publication from the ILCAP, in which they looked at their 20,000 screening patients, screening subjects, that they've done since the NLST closed. And basically they looked at how many of them with nodules found on the preliminary CT scan from size 5 to 9 millimeters wound up going on to having cancer. How many from 9 millimeters to 15 millimeters? And the right column, when I'm looking at the screen, shows that in that smallest group of nodules, there was only 8 cases. Whereas greater than 1.5 centimeter, 15 millimeters, there was 85 cases of cancer. So clearly, the probability of having a cancer changes with these nodules. And so they proposed, instead of going after these 4 and 5 millimeter little ditzels, if you waited and only did interventions, diagnostic interventions above 8 millimeters, you could reduce the number of diagnostic workups by 75%. And you only slightly delayed the detection of still stage 1 lung cancers by very few numbers. And so again, increase the efficiency of the process by studying the data and understanding something about the clinical behavior of the disease. So this is the kind of continuous process improvement we would love to see continue. And clearly, as shown by Cheryl, there's an enormous public health impact. We modeled it. What if you could take advanced stage disease and move it to early stage disease along the directions that they're proposing in terms of the benefit we just talked about from lung cancer screening? Well, here's the numbers. The true life years saved potentially if you successfully implemented lung cancer screening and you had the benefit of the higher rates that we talked about from those other publications I previously cited. It's like 1.6 million person years of life. It's enormous. This is a hypothetical. This is not real data. And even if you thought that there was a certain fraction, say a quarter that was overdiagnosis, you still would have a profound impact in saving premature death. So this is my last slide. This comes back to the work of Lung Cancer Alliance, and Amy Copeland will be happy to tell you more about this. What Lung Cancer Alliance is saying, in addition to what Andrea talked to you about, was that we have no federal regulation about how to do lung cancer screening like we do for breast cancer screening. That took 3 decades to get in place, and that was reactive evolution of care as opposed to proactive. So we're saying we're starting lung cancer screening presumably when we get the final statement from the U.S. Preventive Services Task Force with a recommendation for lung cancer screening at the end of this calendar year. That's when it's going to happen, okay? So instead of making a bunch of mistakes and then having a law 15 years from now, let's leverage the breast cancer experience. You know, more women, almost twice as many women die of lung cancer as breast cancer. So let's use that positive experience and let's pull best practice up front. And let's get people to commit to doing best practices as defined in that room where you sort through all this stuff. I guess we'll have Chris Christie do that for us. And in any event, that data from all those institutions that do that has to be saved, and it has to be pooled, and it has to be analyzed, and we have to get at the other ways that we can approach more efficient lung cancer screening care. By doing that, we'll manage cost, we'll have more financial resources to use for other preventive services, to make sure that we have the people to help us to support the screening process so it gets not just to the worried well, but to all individuals that need it. And in doing that, we could have a system that evolves, saves lives, saves money, and allows the world to be a slightly better place. I'll stop there. Thank you very much.